FADIC offers a variety of international online trainings accredited by FADIC and provided by well-reputed professionals in the field, which means that you can always keep up with the latest topics in your specialty wherever you are and whenever you need it.
أنا ناهد أنا Head of Clinical Pharmacy Unit في واحدة من مستشفيات الوزارة. برضو أنا Antimicrobial Stewardship Senior Pharmacist. إن شاء الله اليوم حنتكلم عن ال Diabetic Foot Infection. كان في كيس صغيرة يعني حصلت لنا في المستشفى، فأنا إن شاء الله بإذن الله أنا أتكلم عنها. The patient is a 56-year-old man presents to the emergency room with a 2-week history of right infected foot wound, long-standing unhealed wound that worsened despite receiving course of antibiotics. So he was on augmentin, parenteral, then oral. The wound was associated with pain, edema, redness, and tenderness. There were also purulent secretions. The patient is diabetic, hypertensive, with ischemic heart disease, with past history of bypass surgery, and he is blind since 2 years. الميديكيشنز اللي كان هو عليها يعني home medications, it was aspirin OD, clopidogrel OD, insulin Mixtard, 25 units in the morning and 15 units in the evening, plus pantoprazole. But unfortunately, when he came to our hospital, we don't have pantoprazole oral, so I couldn't offer omeprazole or esomeprazole because of clopidogrel. So I offered what was that? I offered ranitidine 150 milligram BID. Despite he was his creatinine clearance was borderline 54 something. The patient's also medications were furosemide 40 milligram OD, carvedilol 6.25 milligram BID, and simvastatin 20 milligram HS. The patient is married with the 7 children. With physical examination, the patient was febrile. Pulse was 65 beats per minute. Blood pressure was 152/73. Respiratory rate 18 breaths per minute. His weight was 80 kg. The chest was clear. Mental status, he was conscious, alert, and oriented. With the ECG shows it cannot rule out anteroseptal myocardial damage consistent with the inferior infarct. Chest wall was normal. Abdomen soft and lax. Genitalia pelvic examination was normal. Bones and joints. Right foot infected, smelly wound with pain, edema, redness, erythema, and tenderness. And as I said, there was a purulent secretion. And nervous system, no deficit. The lab results, there was no leukocytosis. His hemoglobin was a little bit low, 11.2. His hematocrit was 30.2%. The random glucose was normal, 4.4. Blood urea nitrogen was much more high, 16.1. And the serum creatinine was a little bit high, 150.61, and his creatinine clearance was 54.9 milli per minute. There was hyponatremia, 128 millimole per liter, and his potassium was normal, 3.9. The cause of admission, the patient was admitted to the hospital for intravenous antibiotic administration. So firstly, we hold aspirin and clopidogrel. Then the patient was taken to the OR for aggressive debridement with the 3rd toe and cleans wound. Then we asked to obtain deep tissue culture before starting any antibiotic. Actually, The patient, when he presented to the emergency department with signs and symptoms of diabetic foot, but no associated with fever or leukocytosis. So the case was, we admitted the case as a moderate case of diabetic foot infection that requires hospitalization with initial parenteral followed by oral antibiotic for 1 to 3 weeks. الconsultant of general surgery, he asked me for advice in this case, because he suspected MRSA from the smelly wound. So he wanted an antibiotic agent that covers MRSA plus antibiotic that covers Pseudomonas. So the surgeon needed something like beta-lactam antibiotic plus MRSA antibiotic. So he suggested linezolid as the patient suffering from mild to moderate renal function with the creatinine clearance 54.9. However, my suggestion was, because when I interviewed the patient, he gave a history of taking carbamazepine for diabetic neuropathy. The patient ممكن ياخذ ممكن يستخدم تاني الكربامازepine either from his stock, because he will be on linezolid for a long period of time, so he might get this carbamazepine either from his stock or from any other hospital, and this may interact with linezolid, leading to serotonin syndrome. And also, besides this, linezolid is associated with a significantly higher cost than vancomycin. So I suggested to use vancomycin, but with monitoring the dose. According to guidelines, the patient has to receive antipseudomonal beta-lactam like piperacillin tazobactam. We call it tazocine. لكن unfortunately الantibiotic هذا is out of stock in our hospital, so I need to find alternative for tazocine. So I offered cefepime plus metronidazole. So my suggestion was to start cefepime and the dose either 1 to 2 grams. I was very hesitated about this dose. Either 1 or 2 grams every 12 hours, as it's antipseudomonal beta-lactam. And I put this note for the nurses for the IV administration to reconstitute 1 gram vial with 10 ml of normal saline, then further dilute for IV infusion, then infuse over 30 minutes. Plus, we can use metronidazole 500 milligram every 8 hours to cover anaerobes. Also, we need to cover MRSA with vancomycin, but with careful dosing adjustment to reduce the risk of nephrotoxicity and ototoxicity. The patient is blind, so we don't need to also affect his hearing. So what I did is I suggested to firstly do hearing test. So the first hearing test was done before we started vancomycin, and planned to do the second before discharge. So we plan to keep the patient for about 1 week for IV administration, then he could continue on oral antibiotics. So I suggested to start vancomycin IV 2 gram loading dose with reconstitute 5 milligram vial with 10 ml sterile water for injection, and then further dilute with 500 ml sodium chloride prior to administration, and infuse over 2 hours to avoid Redman syndrome. And then we could start maintenance dose of vancomycin 1 gram every 12 hours, starting from tomorrow, from the second day. And I wrote a note that please note that the trough level should be withdrawn before fourth dose by half an hour. And due to renal dysfunction, بالنسبة لي هذه البوينت كانت جدا صعبة. أنا يعني إيش أقدر أسوي بالضبط، لأن البيشنت هو مش على hemodialysis, so we could use vancomycin after hemodialysis in 3 times a week, and also he doesn't have normal renal function. So what I did, the plan was to measure the trough level before each dose. لكن المشكلة إن إحنا بنبعت كل الليفلز to another hospital، هو للمستشفى الإقليمي. فإحنا في المستشفى إحنا نفسنا ما عندنا اللي هو ما بنحسب الليفل، فبنبعتهم لمستشفى ثاني. فكانت it would be very difficult to measure the level before each dose. So على حسب الفورمولا هم بيشتغلوا عليها الكلينيشنز اللي هم النفرو consultants، بيشتغلوا على فورمولا اللي هي 150 plus 150 plus GFR multiplied by 15, and this yielded 973.5 milligram, so it was approximately 1 gram every 12 hours. علشان كذا أنا عملتها 1 gram every 12 hours, and before the fourth dose بعتنا ال level. So sample was sent to measure trough level before the fourth dose, and the level وصلتنا الليفل بعد كذا اللي كانت 18 microgram per ml, and the regimen was continued for about 1 week. في خلال during this time the patient was clinically stable and the wound was getting better, and dressing was changed daily. يمكن الكونسلتنت كان شايف انه في الحمد لله كان الwound is getting better, but the patient يعني refused to stay more than 1 week, وكان يعني حيشوف مكان ثاني، مستشفى ثاني. لكن الحمد لله بالنسبة for the culture result sorry, for the culture result was received 5 days later بعد ما بدأنا الفانكومايسين، بعد ما بدأنا الرجمن، revealed Klebsiella and E. coli. كانت sensitive للإمابينم، ciprofloxacin, clindamycin, augmentin, and it was intermediate or partially sensitive للسيفيبين. وبعدين upon discharge يعني تقريبا within 1 week we suggested to continue on oral antibiotics. أنا كان my suggestion to continue إن إحنا بنغطي الأورال antibiotics لأنه طبعا diabetic infection بتكون غالبا polymicrobes. فأنا من قبل لا توصلني الريزلت of culture كان البلان بالنسبة للأورال antibiotics إني بغطي البوليميكروبس، السودوموناس والMRSA والأنيروبس. So we plan to continue on oral antibiotics for a total duration of 3 weeks. So I suggested ciprofloxacin PO 500 milligram every 12 hours to cover gram negative. وبعدين فكرت في الكليندامايسين. أنا حسيت إنه drug of choice في هذه الحالة، فديته 300 ملغ every 6 hours على أساس من ناحية economically ومن ناحية اللي هو patient compliance حياخذ يعني antibiotic واحد to cover both anaerobes and MRSA. وكذلك إن إحنا we stressed on mainly اللي هو بالنسبة لل non-pharmacological therapy. عادة بتكون to this patient or any other diabetic patient mainly preventive therapy through examine, feed daily for calluses, blisters, and trauma. Wear properly fitting shoes, no barefoot walking, and also keep feet clean and dry, and have toenails cut properly. فإن شاء الله بإذن الله إن إحنا أنا أتمنى إني قدرت أعرض الكيس هذه يعني بالتفصيل، أو يعني وكانت كويسة إن شاء الله. بس أنا حابة بصراحة إني أشكر مجموعة فادك وعلى رأسهم الدكتورة يعني الدكتورة رشا، لأن يعني بصراحة استفدت أنا جدا 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 الحمد لله من الكورس هذا. بسايد أنا بالنسبة لي في المستشفى استفدت وأفدت اللي موجودين الحمد لله، سواء الكوميتي أو المستشفى كامل. كذلك الحمد لله إحنا كان عندنا أنتيبيوتيك اللي هو أنتيبيوتيك كان سيمبوزيوم، عملت فيه محاضرتين وكانت مقتبسة من محاضرات فادك، والحمد لله أخذت عليها شهادة شكر. برضو بالنسبة لي عندنا كان اللي هو أسبوع المضادات، عملت محاضرة جدا الحمد لله. يعني المدير عام الشؤون الصحية كان موجود وتكرمت الحمد لله. فكله بفضل الله سبحانه، ثم بفضل فادك وبالأخص الدكتورة رشا. يعني أنا أحب جدا أشكرها الدكتورة. برضو الأسبوع الماضي الحمد لله قسم الصيدلة الإكلينيكية في المستشفى بتاعنا أخذ اللي هو الخدمات الصيدلانية المتميزة لعام 2017، برضو فيما يخص بالذات في الانتيبيوتكس. وبرضو أرجع أقول بفضل الله سبحانه وتعالى بفضل مجموعة فادك. فأنا بصراحة يعني أشجع يعني كل اللي يبغى يحضر كورس يحضره مع الدكتورة رشا. شكرا جزيلا يا دكتورة.
FADIC. Revive your clinical career.